Like guided interviews with opportunities for direct observation, we perform all our ICAR assessments on site, and they're voluntary, consultative, non-regulatory, and of course free. To date, we've been to over 100 facilities in various settings. We primarily have visited acute care hospitals, nursing homes, and we're still performing assessments, so these numbers are actually constantly changing. Each tool contains a different number of domains or overarching infection prevention areas with questions on policy, practice, competency, and auditing. Across settings, some of these domains overlap. Also, the CDC has provided definitions for competency-based training, competency assessments, and audits, which I've copied onto this slide. So when we ask about competency and auditing on site, we're generally looking for competency-based training programs that include a return demonstration component and an auditing program that includes documentation of these audits and feedback to staff. This flow chart depicts an ideal scenario where competency assessments include return demonstration of skills, and audits of practice are not only fed back to staff, but are integrated into a larger quality improvement plan for facility and staff improvement. This is actually rarely observed in the field. Solutions to this approach can include variables like staff time, the availability of designated infection preventionists, or staff turnover. Through our assessments, the team has identified themes where facilities typically note opportunities for improvement. Injection safety, point of care testing, personal protective equipment or PPE, and environmental cleaning are common domains. But all facility types identify gaps with competency and auditing. Keep these themes in mind as I move along through the setting-specific gaps. First, I'm going to share our acute care findings. This graph illustrates no's and yeses for each acute care domain. More specifically, the percent corresponds to the percent of assessed facilities who answered no to one or more questions in a given domain. All of the following graphs have the same layout. The graph allows us to identify gaps in a few domains, the most notable being personal protective equipment, PPE, the prevention of catheter-associated urinary tract infections, or CAUTI, and injection safety. A deeper look into each of these domains reveals that the largest gaps correspond to competency and auditing. For long-term care facilities, the largest gaps are in the PPE, antibiotic stewardship, and hand hygiene domains. The hand hygiene gap corresponds to the lack of alcohol-based hand rub. Of our assessed facilities, more than 70% did not promote alcohol-based hand rub, preferring soap and water instead. The CDC actually recommends alcohol-based hand rub because it's the most effective product for reducing the number of germs on the hands of healthcare providers. And more information can be found at the CDC Clean Hands Count website, which I've provided. With PPE, the same themes of competency and auditing also apply to long-term care facilities. And finally, antibiotic stewardship. So this past November, CMS implemented Phase 2 of their Conditions of Participation, which includes some antibiotic stewardship components. Although we can't say just yet, we expect that any future long-term care facilities we assess will have made more progress on their antibiotic stewardship programs following this CMS update. Outpatient facilities are particularly strong, but it's important to note that the majority of these assessments were conducted in ambulatory surgery centers. Here we saw opportunities for improvement in injection safety, respiratory hygiene, and device reprocessing. Both the injection safety domain and the device reprocessing domain reveal gaps in competency-based training and auditing. The biggest difference is probably the respiratory hygiene domain. These gaps involve offering face masks to patients who are ill and providing space in waiting rooms so that symptomatic persons can sit away from each other. During our site visits, facilities mentioned pre-op phone calls with patients to discuss any illnesses, and rescheduled patients that were sick. If a patient still came in and was visibly ill, they were also rescheduled. And additionally, the size of the waiting rooms varied from facility to facility and sometimes did not have a lot of space. Thinking about the graph on the previous slide, other domains with notable gaps like hand hygiene or PPE on the whole had opportunities for improvement in their competency-based training and auditing programs. And finally, the hemodialysis setting. The team noticed the largest gaps in infection control program and infrastructure domain. Other opportunities included the catheter and vascular access and injection safety domains. The gaps in the infrastructure domain correspond to participation in quality improvement initiatives like those developed by the CDC or the End-Stage Renal Disease Network. The other opportunity for improvement was in isolation rooms. Although dialysis facilities all had hepatitis B isolation rooms, several did not have rooms to isolate patients with conditions other than hepatitis B. Additionally, almost all the facilities we assessed did not utilize antibiotic ointment during catheter exit site dressing changes. And finally, the injection safety domain asks if facilities utilize a clean room that is physically separate from the treatment area for storage and preparation of injectable medications. More than half of assessed facilities did not have this, but some facilities also stated that no such room was available. Several facilities also did not use manufacturer pre-filled syringes or single-use saline vials and instead drew from a patient-designated saline bag, the patient's dialysis line, or a common saline bag. Updated guidance from CDC CMS that was recently released supports using single-use vials or pre-filled syringes. So since this update, all of the facilities we visited actually have used pre-filled syringes. We've discussed where facilities could improve, but I also want to mention what facilities do well. Across the board, facilities were strong in the infrastructure, healthcare personnel, and surveillance domains. Facilities in general had policies that reflected best practice, and individuals trained in infection prevention were available. Facilities also had exposure control plans and work exclusion plans to prevent the spread of illness. Finally, facilities were aware of the reportable diseases in New Jersey, which I've shown here, and had contacts and relationships with the local health department. So what happens after these assessments? Approximately 6 months after their ICAR assessment, facilities are invited to schedule a follow-up call with the ICAR team to discuss changes. Initially, follow-ups were 1-hour phone calls, but we've adopted an online questionnaire approach that facilities complete on their own time. After completing follow-up, facilities receive a certificate of appreciation, which is addressed to their facility. As I mentioned earlier, setting-specific ICAR tools were used on site assessments, but each tool includes different domains. We amended our follow-up process to include domains that were of interest and combine them into groups to allow comparisons across settings. This flowchart lists the domains of the ICAR tool, the differences in settings, and is color-coded to depict the groups included on follow-up. The groups are hand hygiene, personal protective equipment, injection safety, which includes point-of-care testing, and also cleaning and disinfection. On follow-up, facilities were asked about changes in their competency-based training or auditing programs. The questions were posed as checkboxes, so facilities checked what applied to their program. Complete programs included most of the components I have listed, like return demonstration, documentation, and feedback, echoing the questions that we ask on site using the CDC tool. The hand hygiene follow-up also included preferential use of alcohol-based hand rub in most clinical situations. Perfect scores were quantified as 100%, where hand hygiene contributed 40% and all other sections contributed 20%. There were a few reasons why hand hygiene contributed to the largest percent to the overall score, but perhaps the biggest reason is the value of hand hygiene in infection reduction of healthcare-associated infections. Hand hygiene is widely studied, and although it's considered basic, it's also important. Oftentimes, hand hygiene is described as the building block of infection prevention. On follow-up, all of the facilities were asked about hand hygiene, and they were the same questions that we asked on site, irrespective of the facility type. So initially, average scores on site and follow-up scores were compared by setting. The biggest and statistically significant difference was seen in long-term care facilities. And even though they're not statistically significant changes, on average, facilities did improve following an ICAR assessment. This graph shows those same individual groups included in the overall score. Perhaps the biggest increases were in PPE and injection safety for long-term care facilities and acute care facilities, but further analysis is necessary to determine those specific changes. Anecdotally, facilities did report that ICAR resources, including their summary report and other educational initiatives, were used following their site visit. So what have we learned? We learned that facilities use setting-specific tools, which can and do overlap in some content areas. We learned that although the gaps we discussed were dependent on setting, there were still common gaps across settings. Initial follow-up data is promising, showing that facilities were able to improve infection prevention programs, but more analysis is necessary. We also saw the biggest gains in long-term care facilities. And finally, Jess will elaborate on what educational initiatives facilities were able to use following their site assessments. So with that, I'm going to pass the mic over to her.
Thank you, Rainey. My name is Jessica Felix. I am a nurse infection preventionist with the ICAR team, and I'm just going to take a few minutes this morning to share with you all the educational offerings and different resources associated with our ICAR activities. So as Rainey explained, the ICAR assessment is an on-site collaboration with tool review and observations. We also bring along a resource bag that corresponds to the setting-specific domains, which includes a GlowGerm mini kit and instructional flyer on how to use it. The GlowGerm mini kit consists of a 4-ounce bottle of GlowGerm and a keychain blacklight, which is depicted on the left side of your screen. So thus far, close to 800 staff have been trained using the GlowGerm from all different areas. Many facilities included their contracted services such as transport, environmental, dietary, their physical, occupational, and speech therapies, as well as any students for training in either hand hygiene or environmental cleaning. The use of GlowGerm is a fun, interactive way to incorporate that competency-based training that we commonly see in opportunities for improvement for, especially for visual learners. So for those of you who are not familiar with GlowGerm, it is a fluorescent marker which is used to simulate germs. The two ways that we shared of using it was for the hand washing, also environmental cleaning. So for hand washing, staff would apply the GlowGerm as a lotion. The picture on the lower right depicts what it looks like on the skin under a black light. Staff would then wash their hands per their facility policy and recheck their hands under the black light. So for the most part, with adequate friction and hand washing, that GlowGerm would be removed and there would be no luminescence on the skin. When GlowGerm is used in the environment, the staff would go mark a room that's scheduled for a routine or terminal clean, either the night before or earlier that day using the GlowGerm. Then environmental service staff would clean the room as scheduled and then go back with the black light to evaluate if there were any issues or oversight in the cleaning process. So if there was oversight in the cleaning process, the GlowGerm would luminesce as pictured on the slide. One of the things that we emphasize when sharing this resource with facilities is that the exercise should be used for educational purposes as opposed to punitive. And in addition to verbal feedback that we do the day of the assessment and the section of resources that are in the back of the actual CDC ICAR tool, we develop a written facility-specific summary report to send to facilities post-assessment. So the New Jersey ICAR summary report takes a deep dive into each domain, highlighting what the facility is doing great, identifying opportunities for improvement with additional resources a click away. Most of the resources are hyperlinked within the report for ease of access, allowing facilities to prioritize which domain they would like to address, not really to overwhelm them with a ton of content at once. Our first large-scale education was the Healthcare-Associated Infections Conference at Mercer County Conference Center in May of last year, with a turnout of over 200 attendees. CDC spoke on clinical and economical impacts of HAIs, followed by a raffle of about 40 items, which included a bunch of goodies such as the APIC text, different HAI and EPI textbooks, the Evelyn McKnight book, A Never Event, describing her experience with contracting hepatitis C while battling breast cancer due to syringe reuse, goodness, those injection safety issues, and then also glow germ bundles, which was a big hit. The afternoon consisted of repeat breakout sessions, including the ICAR participants, 3 different participants, sharing their experience with the ICAR assessment and how it had impacted their practice. So with a focus on sustainable education, we wanted to offer resources that were readily available with ease of access. The team has developed webinars, resource documents, and a video series in an effort to help with gap mitigation, keeping sustainability in mind. So videos are great, especially for visual learners. However, the real added value comes from this ICAR video leader guide. The guide is a 10-page document that prompts facilities to take a second look at their policies, procedures, and practices. It provides the staff educator or session facilitator with canned questions to stimulate discussion and engage staff, encourages facilities to have copies of policies and procedures available for staff to review, and really just take a deep dive into the why or the rationale for doing all the proper steps, especially when we talk about cleaning and disinfection. And so the ICAR videos that were created capture safe glucometer use, medication preparation areas, and injection safety. These videos were debuted in May of last year via webinar and have a combined total of over 1,600 views. These videos run about 3 to 5 minutes in length and were filmed with a partnering ICAR facility, St. Lawrence Rehabilitation Center. So the glucometer video depicts a nurse collecting a blood specimen using poor practice with a pause and discussion point, followed by a nurse collecting blood specimen using appropriate technique. The video also places special emphasis on hand hygiene opportunities throughout the process, as well as the cleaning and disinfection. The medication preparation video highlights the importance of aseptic technique and ensuring a clean area for medication preparation. There's also emphasis on the process of cleaning versus disinfection, so the difference between the two. And then last but not least, in the injection safety video, which highlights the one and only campaign and safe injection practices, the video echoes the 1 needle, 1 syringe, 1 time, and discusses single dose versus multiple dose medication vials. And so our most recent webinar was in September of last year and focused on antibiotic stewardship in the long-term care setting. The webinar featured 3 ICAR participants sharing their different approaches on how they implemented programs in their facilities. This webinar had over 250 registrants, including CDC staff, which led to one of our New Jersey ICAR participants being featured on a CDC national call for grantees and other state and public health partners addressing antimicrobial resistance and stewardship. So what's next? Future plans for our sustainable education efforts are ongoing. The team is working on a resource guide entitled Guidance and Recommended Resources for Infection Prevention Partners. The guide is in a draft form with hopes of being shared in the next month or 2. It's ultimately a what you need to know guide for infection preventionists and loaded with tips and resources that'll benefit all infection prevention partners. There is also an appendix which breaks down the ICAR tool by domain and highlights excellent resources that we've picked up along the way. While the team is excited to continue these activities over the next year and ideally maintain ICAR activities to some capacity at the Communicable Disease Service, this CDC program offered a one-time supplemental funding, which means that this program will not continue in its current capacity throughout the nation. For facilities who may not get the opportunity to participate in an on-site assessment, we encourage them to perform a self-assessment and use the IP guide appendix previously mentioned to enhance their current program or mitigate any gaps identified. And then last but not least, the team is working on a collaborative webinar series with our DOH partners at Health Facilities Survey and Field Operations to highlight common infection prevention tags identified compared to our ICAR findings and highlight what resources are available to prevent future tags. This series would be setting specific and address long-term care, hospitals, ambulatory surgery centers, and dialysis clinics. With that, I would like to thank you for your time, and if you have any questions, please put them in the chat box and we will address them at the end of the webinar.
Thank you guys, that was great. The ICAR program is really a quite good program that I wish could continue as it currently is. So please, if you have any questions for Jessica or Rini about ICAR, I believe they are still doing assessments. Are you guys still doing? Yeah. So if you know of any facilities you think could benefit from an ICAR assessment, please give the team and send them an email, all that good stuff. All right, so that brings us to our second speaker, our second presentation rather. Deepam Thomas is our foodborne disease surveillance coordinator, and Tara Fulton is the epidemiologist that works as also our laboratory liaison. So they're going to talk about detecting a multi-state outbreak linked to papayas. Take it away, Deepam.
Good morning, everyone. I'm Deepam Thomas, and as Laura announced, I'm the Foodborne Disease Surveillance Coordinator. And today we'll go over cluster detections and investigations with a focus on the recent multi-state outbreak of Salmonella infections linked to imported papayas. So what exactly are the steps involved in a multi-state outbreak investigation? All the steps that I've listed above are ones that you've probably heard me talk about before. And in any outbreak investigation, like in the flowchart to your right, there is a lot of retracing previous steps before finally being able to determine the source or even deciding that the outbreak is over. However, the three main roles remain: quickly detecting the outbreak, gathering evidence linking the outbreak to a likely food or animal source, and communicating these results to consumers and retailers to prevent further illness. How different is a multi-state outbreak from the traditional foodborne local outbreak? So this is the scenario with which you are all very familiar. This scenario includes an acute and mainly local outbreak with a high attack rate. It often follows a local event such as a church supper, a family picnic, a wedding reception, or any other social event. And typically, the outbreak is quickly apparent to those attending. So they're usually the ones who prompt this investigation. They don't notify you or their medical provider. The investigation mostly stays local, so it involves investigators at the LHD level, regional EPIs, the foodborne team within CDS, and identifies a food handling error or a sick employee or host that occurred shortly before the consumption of the implicated food. The solution is also local. So it involves education of food workers, changes in the food service establishment policies, maybe operating procedures. To the right, I have the proportion of outbreak-associated illnesses caused by each food commodity. To the right of this slide, I have the top 5 food germ pairs that caused outbreaks in 2015, but this slide mainly describes a multi-state outbreak. So unlike a local outbreak, these outbreaks are the result of low-level contamination of a widely distributed commercial food product. So only a few cases occur in most jurisdictions. As a result, the increase in cases may not be apparent against the background illness. So the outbreak is detected only because of a concentration of cases in one location, either because the pathogen causing the outbreak is unusual, or because subtyping of strains identifies a surge in one subtype. So in such outbreaks, investigation can require coordinated efforts of a very large team. So that would help clarify the extent of the outbreak, implicate a specific food, and determine the source of contamination. Often there are no obvious food handling errors found. Instead, the contamination is usually at the industrial level. So it's either production, processing, or at the distribution level. These outbreak numbers are increasing over time, especially as food production becomes more centralized and globalized, and our ability to detect multi-jurisdictional outbreaks improves. Large multinational corporations are producing a greater proportion of the food supply, and if there is a problem in the food supply, it can rapidly be amplified through this system. A problem in one facility is likely to show up in many different states. Also, there are changes these days in food preferences, and that has resulted in a greater demand for a broader variety of fruits, vegetables, and other foods. So the food industry has, of course, accommodated this demand by moving from locally grown and raised products to routine importation of items that were once considered out of season or too exotic to buy. The adequacy of food safety programs outside the United States is sometimes questionable. Also, the use of more discriminating subtyping methodologies such as PFGE or pulsed field gel electrophoresis and whole genome sequencing have allowed cases from widely remote geographic locations to be linked and investigated. What does this increase mean? It means we will all continue to be involved in multi-jurisdictional outbreak investigations for a long time. Multi-state outbreak indicators. Prompt local health department case investigations help identify local foodborne outbreaks, and these sometimes might herald a larger problem. So it is very important that the local health department investigators quickly recognize these outbreaks, notify others when they suspect that the outbreak might be more diffuse. Some indicators suggestive that an outbreak is likely to involve cases residing in different jurisdictions include when the suspected or implicated food item is contaminated before the point of service. So an example would be a commercially distributed, a processed, or ready-to-eat item. Fresh produce, for example, the leafy greens that was associated with the recent E. coli 015787 outbreak. Or if there are illnesses linked with multiple restaurants or food service establishments. The molecular subtyping of agents match patterns associated with outbreak in other locations. That's another indicator. If the setting of outbreaks involves exposure of persons who have been subsequently dispersed. So for example, if there's been a state fair, a family reunion, or a convention center or an airport from where people have gone away and got dispersed. So now let's take a closer look at a multi-state outbreak, the progress of investigation, and roles that state and local jurisdictions played. So on March 1st of 2012, a state health department notified CDC's outbreak response team of a cluster of 4 ill persons infected with Salmonella borrelii with the same unusual PFGE pattern. Sometimes an unusual cluster with rare subtyping results get picked up by local health department investigators. All state public health labs upload their PFGE results to CDC's PulseNet platform. And PulseNet is a national laboratory network that began in 1996, and it uses DNA fingerprinting to help connect foodborne illnesses cases to detect outbreaks. So on March 2nd, PulseNet revealed that 11 persons in 7 states were infected with the same Salmonella strain. CDC then began coordinating a multi-state investigation. They held their first multi-state conference call for this outbreak, and common exposures based on existing LHD investigations were reported by states. And they included chicken, seafood, fresh produce, and Japanese restaurants. This is where the timely investigation, as soon as a case is identified, becomes invaluable. At this point, CDC typically requests the use of National Hypothesis Generating Questionnaires, or NHGQs, by states so that findings become more comparable. On March 8th, exposure information from 8 ill persons revealed that 7 people reported eating seafood and 5 ate sushi in the week before becoming ill. Since most states have only 1 to 2 cases, comparison of case information across states is critical for this initial stage. Between March 8th and 13th, State B reported the first cluster of 2 unrelated ill persons who ate at the same Japanese steakhouse which served sushi, and State C reported a second cluster of unrelated ill persons eating at the same Japanese restaurant. Clusters among unrelated people who ate at the same restaurants were of note because they allowed investigators to now conclude that whatever was causing the outbreak was served at these restaurants. In addition, these clusters also allowed investigators to perform a traceback investigation to identify what specific food ingredient was shared by all of these restaurants that could have caused the outbreak. Because of the growing evidence in support of sushi as the outbreak source, a focus questionnaire was developed, and this included more specific information on sushi type, the ingredients, the garnishes, and side dishes that are more commonly seen during a sushi meal. On March 15th, FDA began receiving supplier and invoice data collected by state and local health departments. And between March 16th and 27th, one state reported a third cluster, 2 states reported 2 other restaurant clusters, and 1 state even reported a grocery-related cluster. 90% of the cases for whom a focus questionnaire was completed reported eating spicy tuna. Between March 29th and April 9th, a case control study was undertaken at 4 restaurants linked to the outbreak. The type of sushi was compared between cases and others ordering sushi at these restaurants, and preliminary results showed that 84% of the case meals and 37% of the comparison sushi orders contained spicy tuna as an ingredient. On April 10th, one of the states notified CDC about 5 recent Salmonella Nachanga infections occurring in the same states as the Salmonella Borrelii cases. Initial interviews showed that the case patients had similar spicy tuna sushi exposures. One case patient ate at the same sushi restaurant as a Salmonella Borrelii case patient. So that's where it gets interesting. Because of this overlap now, the 2 outbreak investigations were merged. By April 14th, traceback investigations determined the common product was a frozen, raw, yellowfin tuna from a single processing facility in another country. The company voluntarily recalled pre-production dates of frozen, raw, yellowfin tuna product. CDC and FDA want people not to eat the recalled product, and FDA issued 2 import alerts for fresh and frozen tuna from this company. Between April 19th and 24th, FDA conducted a seafood inspection at this processing facility, and inspectors identified several deficiencies. So there were significant sanitation concerns, including contamination of tanks used to store processed waters, visible product residue on the ceiling directly above the in-service tuna line. There were product residues and rust on knives and utensil storage boxes, bird feces on the ice manufacturing equipment, insects and filth on the equipment, and finally, no hand drying devices available in employee restrooms. By April 26th, FDA found outbreak strains of Salmonella Borrelii and Salmonella Nachanga in unopened packages of imported yellowfin tuna product. So there were a total of 425 Salmonella Borrelii and Nachanga infections identified in 28 states and the District of Columbia. The median age of cases was 30 years with an age range of 1 to 86. 60% of the cases were female, 17% of the cases were hospitalized, and New Jersey had 42 cases in this 2012 outbreak. PFGE versus whole genome sequencing. The outbreak I just went over used PFGE to identify cases, and this is still the current gold standard fingerprinting method used within PulseNet. However, PulseNet is transitioning towards using whole genome sequencing. There are plenty of resources available explaining these testing methods, and I will not go into a lot of minute details, but just to quickly compare, how exactly does PFGE work? So bacterial cells are taken from an agar plate, and you can see that in the picture on your slide. They're broken open with biochemicals so that the DNA is free. This is then loaded onto a gel and placed in an electric field. This field separates the DNA fragments according to their size. The gel is stained, and so that the DNA can now be seen under UV light. A digital camera then takes a photograph of the gel and then stores this picture onto the computer. The DNA fragments produce a DNA fingerprint with a specific pattern. And once a DNA fingerprint is created, the public health lab analyzes the patterns using bionumerics. These patterns get uploaded to the national database, or PulseNet. Here, PulseNet experts investigate the pattern to see if it is causing an outbreak or if it is part of an ongoing outbreak. If so, this information is communicated back to the states to further investigate the outbreak. A few disadvantages of PFGE are that 1, it's time consuming. It does not discriminate between all unrelated isolates. The DNA restriction patterns can vary slightly between technicians. Some strains cannot be typed by PFGE at all, and most importantly, it does not differentiate isolates to the same degree that can be achieved by whole genome sequencing. So what then is whole genome sequencing? So this process begins with DNA shearing. Scientists begin by using molecular scissors to cut the DNA, which is composed of millions of bases. So you have your A's, C's, T's, and G's into pieces that are small enough for the sequencing machine to read. Small pieces of DNA tags or barcodes are then attached to identify which piece of sheared DNA belongs to which bacteria. This is very similar to how a barcode identifies a product at a grocery store. So the barcoded DNA from multiple bacteria are then combined and put into the whole genome sequencer. The sequencer now identifies a combination of the nucleotides, so the A's, the C's, T's, and G's or bases that make up each bacterial sequence. The sequencer uses the barcode to keep track of which bases belong to which bacteria. This is the DNA library. Experts then use the computer analysis tools to compare bacterial sequences and identify differences. The number of differences can tell you how closely related the bacteria are and how likely it is that they are part of the same outbreak. So clearly, whole genome sequencing provides more detailed and precise data for identifying outbreaks than the current standard PFGE. So instead of only having the ability to compare bacterial genomes using 15 to 30 bands that appear in a PFGE pattern, we now have millions of bases to compare. Right now in New Jersey, while we can PFGE at the state lab, whole genome sequencing for our isolates are only performed at CDC. We are currently in the process of implementing whole genome sequencing here, and hopefully we will be able to whole genome sequence most of our foodborne isolates within the next couple of years. So what then is the role of state and local jurisdictions in multi-state outbreaks? In a nutshell, it becomes very important to notify others jurisdictions of these local outbreaks, to be aware of large multi-state outbreaks so exposures of interest could be picked up quickly on case investigations, to search for local cases or clusters associated with these multi-jurisdictional outbreaks, and most importantly, to get a thorough food history, which is best captured with minimum recall bias as close to the illness onset as possible. The unique exposures you gather could help crack the investigation, and last but not the least, help collect data to support traceback investigations by federal agencies if needed. Now we will quickly move to a poll question, and then Tara will go through a recent multi-state outbreak that made headlines this past summer.
Okay, so that's not it. Hold on a minute. All right, so you have a poll question up here, and it says, the following suggests that cases associated with the local outbreak might reside in multiple jurisdictions except, and you have 4 options. Take a couple minutes. I'm going to open the poll. I'm going to launch it so that you can figure out what you're, oh, we're voting. All right. Oh, this is awesome. All right. Couple more seconds. Oh, it's getting interesting. All right, so let's close it and get the results. Oh. So Deepam, is that the correct answer?
So we have 54% of you who said B, and that is the correct answer. Good job.
Yay!
So the contributing factors were found at the food service establishment during the environmental health assessment. That is the right answer, because finding that would support end user contamination, and that's not an indicator that cases would reside in multi-jurisdictions.
Okay.
So good morning, everyone. My name is Tara Fulton. I'm an epidemiologist for the foodborne team at the Communicable Disease Service. I'm going to be talking about a large multi-state outbreak of salmonella infections that occurred last summer. And I'm going to walk you through the steps that were taken to pinpoint the source of the outbreak, which turned out to be imported MARADOL. So on June 20th, 2017, the CDC notified the New Jersey Department of Health of a Salmonella Kiambu cluster consisting of 13 cases from 8 states. 3 of those cases were from New Jersey. By July 5th, the number of cases rose to 9 in New Jersey and 33 nationally. When the Communicable Disease Service receives notification that a New Jersey resident is part of a multi-state cluster, an additional interview generating questionnaire is used to re-interview the case. As Deepa mentioned, by collecting the same information across states, data analysis is more efficient, and the time it takes to pinpoint the source of the outbreak can be reduced. As cases were interviewed with this national hypothesis generating questionnaire, a few common exposures began to surface. These exposures included pasteurized cheese, eggs, fresh tomatoes, carrots, apples, grapes, citrus fruit, raspberries, strawberries, hot peppers, mangoes, and papayas. By July 13th, there were 44 cases nationally and 12 cases in New Jersey. With additional interviews, common exposures were narrowed down to mangoes, papayas, cilantro, hot peppers, and sprouts. And of note, 60% of cases with known ethnicity were Hispanic or Latino. By the end of the following week, CDC reported that 10 out of 24 people interviewed, or 42%, reported eating papayas. This proportion was significantly higher than the results from a survey of healthy Hispanic people, in which 16% reported eating papayas in the months of May and June. It was around this time that the Maryland Department of Health shared their plans to collect and test papayas from a grocery store where several ill people reported eating papayas. On July 17th, Maryland Department of Health informed FDA, CDC, and state partners that 2 of the samples had tested positive for salmonella. Both of the samples that had tested positive were from the CARIBEña brand yellow MARADOL papayas imported from Mexico. Whole genome sequencing linked one of the CARIBEña MARADOL papayas to the Salmonella Kiambu outbreak, while a different serotype, Salmonella Thompson, was identified in the other papaya. As it turned out, both Salmonella Kiambu and Salmonella Thompson were isolated from samples collected from ill people in the Maryland cluster. It was at this point that CDC started to collect additional information to determine whether the recent Salmonella Thompson illness in Maryland was part of the growing multi-state outbreak. Then on July 24th, CDC reported 17 cases of Salmonella Thompson from 7 states. At the time, 4 of those cases belonged to New Jersey. On July 26, only 2 days later, the count had almost doubled. 33 Salmonella Thompson and 47 Salmonella Kiambu cases had been reported. It was on July 26 that the produce distributor, Grand Produce, issued a voluntary recall of a limited quantity of CARIBEña brand MARADOL papayas distributed during the dates of July 10th and July 19th due to a potential health risk from Salmonella. The following day, the FDA issued an outbreak posting advising consumers to avoid all CARIBEña brand MARADOL papayas, regardless of color or distribution, or date of distribution, FDA tested other papayas imported from Mexico and isolated several types of Salmonella, including Salmonella Kiambu, Salmonella Thompson, Salmonella gaminera, Salmonella agona, and Salmonella Seftonburg. Investigators compared pulse field gel electrophoresis and whole genome sequencing results of Salmonella isolates from the papayas to isolates from ill people in the CDC PulseNet database. These results showed that Salmonella isolates from papayas shared the same DNA fingerprint as the Salmonella isolates from ill people. It was through extensive traceback and testing, FDA identified MARADOL papayas from the Carica de Campeche papaya farm in Campeche, Mexico, as a likely source of the outbreak, and on August 3rd, FDA issued an import alert on the farm. Several distributors issued recalls within the week naming Cabi brand and Valerie brand MARADOL papayas grown and packed by Carica de Campeche. On August 4th, CDC officially added the Salmonella Thompson cases to the Salmonella Kiambu cluster, and by August 16th, CDC added Salmonella agona, Salmonella gaminera, and Salmonella Seftonburg illnesses to the outbreak. Nationally, a total of 220 people were infected with the outbreak strains of Salmonella from 23 states. Illnesses started on dates ranging from May 17th to October 4th. Ill people ranged in age from less than 1 to 95 years with a median age of 40. Among ill people, 62% were female, and among those with available information, 67% were Hispanic or Latino, and 40% were hospitalized. Unfortunately, one death was reported from New York City. 41 New Jersey residents were infected with the outbreak strains of Salmonella Thompson, Salmonella Kiambu, Salmonella agona, and Salmonella gaminera. The Northeast had the highest number of cases, followed by Central East, Northwest, Central West, and the South. Illness onset ranged from May 22nd to September 10th. Ill people ranged in age from 7 months to 92 years, with a median age of 46. Among ill people, 59% were female. Among people with available information, 71% were Hispanic or Latino, and 49% were hospitalized. Of the 31 people with available information, 55% reported consuming papayas and 61% reported papaya exposures of any kind. I want to mention that New Jersey also participated in product testing during this outbreak. During the initial investigation of a reported Salmonella case in Somerset County, an investigator at the local health department learned that the case had consumed papaya prior to illness onset. Upon notification of this exposure, the Communicable Disease Service requested that papayas were picked up from the farmer's market that the family purchased the fruit from and taken to the state lab to be tested for Salmonella. While the papayas tested negative for Salmonella, we did learn that the serotype and pattern of the Salmonella isolate from the case in Somerset County matched the serotype and pattern of the Salmonella isolate that was isolated from a papaya collected in Maryland. This exemplifies how global food production has resulted in food being distributed over large distances and how quickly contaminated food can cause a widespread outbreak. As a result of the ongoing outbreak, FDA increased testing of papayas from Mexico to see if papayas from other farms were contaminated with Salmonella. Through this increased testing, FDA identified other types of Salmonella on papayas from additional farms in Mexico. CDC reviewed the PulseNet database and identified 3 additional outbreaks of people with the same DNA fingerprints as the Salmonella found on papayas from 3 farms. These outbreaks included Salmonella annotum, Salmonella Newport and Infantis, and Salmonella urbana. New Jersey had 5 residents that were part of the Salmonella urbana outbreak, 3 in the Central East, 1 in the Northeast, and 1 in the Northwest. Illness onset ranged from July 23rd to August 14th. Unfortunately, young were disproportionately affected, with 4 out of 5 cases being under the age of 2. 60% were female, 80% were Hispanic ethnicity, and 40% were hospitalized. Among 4 people with available information, 50% reported consuming papayas and 75% reported papaya exposures of any kind. These 5 cases were in addition to the 41 cases that were part of the larger salmonella outbreak. So in total, 46 New Jersey residents were reported to have salmonella infections linked to imported MARADOL papayas. This was close to 20% of the total number of people affected nationally. Needless to say, New Jersey was hit particularly hard with the outbreak. Finding the source of an infection, or an outbreak, is obviously important because the food could still be in stores, restaurants, or kitchens, and therefore it could make people sick. By investigating outbreaks, we can stop them so more people don't get sick, and we can learn about what went wrong to keep similar outbreaks from happening in the future. So thank you to everyone who works on foodborne disease surveillance and investigations at the local, state, and national level.
Wow, awesome. Great. Thanks, Tara and Deepam. Very interesting. Very good. So again, if you have any questions, please put them in the question chat box, and we're happy to respond to your questions. Now, it's my pleasure now to introduce Karen Worthington to talk about new tick information and recommendations. Karen, there you go.
Thank you, Laura.
Sure.
My name's Karen Worthington. I'm a nurse in the New Jersey Department of Health Vector-Borne Disease Group. Today I'll be discussing 2 tick-borne diseases, babesiosis and spotted fever group rickettsiosis. Although they're reported much less frequently than Lyme disease, there's some new information I'd like to pass on about better diagnostic tests and prevention opportunities. Of the more than 100 Babesia species known to infect mammals, only a few have been documented to cause infections in humans. These are B. microti, B. divergens, and B. duncani. Of these, B. microti is the predominant species causing illness in the Midwestern and Eastern U.S., including New Jersey. The B. microti life cycle involves the white-footed mouse as reservoir and the deer tick, Ixodes scapularis, as vector. The nymphal stage of the tick is the primary vector and typically requires attachment to a host for at least 36 to 72 hours. If the tick is carrying the protozoa, the 2nd or 3rd day of attachment is typically when Babesia infection occurs. The incubation period is 1 to 3 weeks after the bite, but longer if the route of transmission is from a Babesia-infected blood transfusion, which I'll talk about in more detail. Babesiosis was first recognized over 50 years ago. Although it shares the same tick vector as Lyme disease, geographic expansion of the disease has been slower. There are an average of 1,386 cases per year reported nationally. 95% of cases are from 4 northeastern states, including New Jersey, as well as 2 states bordering on the Great Lakes. New Jersey's been reporting cases for over 30 years, but between 2001 and 2011, geographic distribution increased from just 8 New Jersey counties reporting at least 1 case of babesiosis to all 21 counties.
Karen, can you just speak up a little bit?
Sure. In New Jersey, between 2011 and 2016, there were an average of 178 babesiosis cases reported per year. For total cases over that time period, the 5 counties with the highest numbers of cases were Monmouth, Ocean, Burlington, Hunterdon, and Atlantic. The Babesia parasite causes disease in humans by entering the blood cell and destroying it, which leads to hemolytic anemia. Some people can overcome the infection, and the spleen is the major organ involved in doing that. But asplenic or immunocompromised persons often develop serious symptoms. Because the parasite takes up residence in the red blood cells, it can be passed from an infected blood donor to a recipient, and also, but rarely, through congenital or perinatal transmission. Many people who are infected with B. microti feel fine and don't have any symptoms. distinguished from other infections solely on the basis of signs and symptoms. Diagnostic testing is required. You can see that the symptoms are similar to other tick-borne diseases, with the highest proportion of persons having fever. The laboratory findings reflect the hemolytic anemia process and the level of parasites in blood cells. The presence of unexplained febrile illness, especially when accompanied by hemolytic anemia, should prompt consideration of babesiosis, especially in persons who live in or have visited Babesia endemic areas or were recently transfused. Most asymptomatic persons do not require treatment. For ill patients, recommended treatment is one of two combination therapies. For persons with high parasitemia levels, however, exchange transfusion can be required. B. microti is the most commonly reported transfusion-transmitted pathogen in the U.S. It's the leading cause of mortality in transfusion recipients. Currently, there are no donor screening tests licensed by the FDA, but investigational screening protocols are taking place in some areas of the U.S., including New Jersey. The FDA, as well as the American Association of Blood Banks, recently categorized Babesia as a high priority agent for development of interventions to reduce the incidence of transfusion-transmitted babesiosis. In a 2011 article, CDC researchers reported that 77% of transfusion-transmitted babesiosis infections were reported in the last 10 years of the 30-year study period, so from 1999 to 2009. 90% of the cases were from the 7 states where B. microti is endemic. The 10% of the cases that occurred in the states where Babesia is not endemic were attributed to blood products shipped from endemic areas. Cases were linked to donations made in all 12 months. 97% of cases were related to transfusion of red blood cell components and 3% to platelets. Most cases were discovered as a result of the recipient of the infected blood product developing clinical symptoms. At the time of publication of the article, few state departments of health were fully investigating possible transfusion-associated cases. In New Jersey, only 3 of the 11 blood collection centers that supply blood products to our hospitals currently perform laboratory screening of donated units. The only approach currently implemented to reduce the transfusion risk is a largely ineffective donor interview question regarding a history of babesiosis. Given that New Jersey is an endemic state, this leaves a lot of opportunity for potentially infected units to be transfused to New Jersey patients. In looking at babesiosis cases for 2011 through 2016, 16 New Jersey cases had a history of blood transfusion documented in CDRSS and were reported to CDC. It wasn't until 2017 that NJDOH began to work with blood collection centers and our state laboratory blood bank program to investigate these recipient cases and better understand responsibilities of hospital blood banks and blood collection centers regarding who does the traceback investigations and tests donors. Identifying a history of blood transfusion in our New Jersey babesiosis cases could enable infected donor units to be pulled from circulation in a timely way, and these donors deferred permanently from future blood donations. Although we realize that the tick-borne caseload is high for local health departments, we'd like to ask that you try to investigate new babesiosis cases opened in CDRSS in as timely a way as possible. To help with this, our vector-borne group drafted a new case investigation worksheet to guide your interview with the healthcare provider and, if necessary, the patient. It lists babesiosis-specific signs and symptoms and the most important risk factors to capture, including history of blood transfusion, splenectomy, or travel to a malaria endemic country. Malaria is a similar parasite to Babesia, and on occasion, confirmation of blood smear results at FEL may be required to assure which one is causing infection. If a history of one or more transfusions is identified in the 12 months prior to the date the positive specimen was collected, we'd ask you to contact the infection preventionist at the hospital where the transfusions took place. And we'd like you to find out the date transfused, type of blood product, and the name of the blood collection center that the product came from. Then enter this information to the comment section of CDRSS and notify your regional epidemiologist. For case classification, we'll start out with the lab results because that's how most cases are opened. The Babesia species we see in New Jersey is nearly always B. microti. Divergens and Donkani are rarely reported in this area. Lindsay Lowe here in CDS tries to review all incoming results to screen out lab open cases that don't meet criteria. But we recommend you double check that the lab results meet confirmatory or supportive requirements before starting an investigation. Confirmatory results include positive smear results, now called microscopic observation in CDRSS, or positive PCR or nuclear amplification test results. Supportive results include B. microti IgG antibody titers greater than or equal to 1 to 256, or positive B. microti IgG immunoblots. Objective clinical criteria are met by one or more of the measured values in the box on the left, so fever, anemia, or thrombocytopenia. Meeting subjective clinical criteria requires a history of one or more reported symptoms from the box to the right. A confirmed case requires confirmatory lab criteria and at least one clinical finding, either objective or subjective. Probable cases must meet supportive lab criteria with at least one objective clinical finding. Classify a case as possible when either type of lab criteria is met, but there's no clinical information. So I think we have a poll question now. Let's see. So we'd like you to classify this Babesia case. And you should be able to see the laboratory results of positive microscopic observation on the screen, as well as the symptom result, which is thrombocytopenia. Oops, lots of people are voting. Okay, we'll close the poll.
75% say it's confirmed.
Very, very good. That's the answer. This would be classified as confirmed because there's laboratory evidence of infection, along with at least one objective, in this case thrombocytopenia, finding. We didn't have a clinical symptom. So very good. We're going to move on to just a little bit. This slide shows some information about transfusion-transmitted babesiosis, but this is informational for you. What we've decided is that investigations of the transmitted babesiosis cases requiring donor traceback testing and linkage to recipient cases will be handled by our DOH staff. This looks like it's going to be a heavy lift because some cases have had dozens of transfusions, and so we just kind of want to figure this out first. So let's talk about upcoming spring and summer activities for babesiosis. So NJDOH will continue completing and will post our updated babesiosis chapter and the new investigation worksheet by the end of this month. We ask that you use the worksheet to gather babesiosis-specific signs, symptoms, and risk factor information, particularly related to a history of blood transfusion. If there was a history of transfusion in the past year, contact the infection preventionist to obtain the necessary information about transfusions, enter it to CDRSS, and contact your regional epidemiologist about the case. So now we'll move on to the second disease we wanted to talk about, spotted fever group rickettsiosis, which you'll probably recognize better under another name. Spotted fever group rickettsiosis are bacterial infections caused by various species of rickettsia and transmitted by several vectors. Our focus today will be on ticks. The best known, most severe, and historically most common is Rocky Mountain spotted fever caused by Rickettsia rickettsii. However, several other species are now known to cause less severe human disease. So in 2010, CDC broadened the name from Rocky Mountain spotted fever to spotted fever group rickettsiosis to reflect this. Currently, challenges exist in accurately diagnosing the causative species within the genus Rickettsia. Ticks serve as both vectors and hosts for Rickettsia. Naive larval and nymphal ticks become infected while feeding on such as mice, squirrels, and chipmunks who are infected with acute Rickettsia. Some rickettsial species can be passed on from parents to offspring. The ticks of concern in New Jersey are the American dog tick, or Dermacentor variabilis, long established here, and the Gulf Coast tick, Amblyomma maculatum, which is encroaching on our state. Less is known about which ticks carry the more recently identified spotted fever group rickettsiosis species. But we'll focus on the American dog tick. It's usually the adult tick that bites humans, and although it prefers to bite dogs, deer, and livestock, it prefers to bite dog, deer, and livestock. The tick needs to be attached for a few days. Bites by ticks in other life stages are possible but less likely. You'd think that since it's an adult tick, a bite would be more easily recognized, but in a study of Rocky Mountain spotted fever patients, only 55 to 60% recalled a tick bite. The incubation period for all spotted fever group rickettsiosis is 2 to 21 days. Rocky Mountain spotted fever symptom onset takes place in a narrower range, 3 to 12 days. Rocky Mountain spotted fever has been a nationally notifiable disease since the 1920s, but the name change to reflect infection with other rickettsial species didn't take place until 2010. As you can see, a steep increase in reported cases began to occur in the 1990s. What CDC and other researchers noticed is that case fatality rates were also declining over this time period. The majority of cases are reported by 5 southern states bordering on or just east of the Mississippi. Most are home to both the American dog tick and the Lone Star tick. In New Jersey, we've had an average of 82 spotted fever group rickettsiosis cases per year since 2011. For total cases in the 6-year period from 2011 to 2016, the leading counties are Atlantic, Ocean, Gloucester, Burlington, and Hunterdon. CDC researchers have the following thoughts about these recent surveillance trends. Overall, they suspect that in many cases, persons presenting with nonspecific illness are testing positive due to existing antibodies from a prior exposure to a non-pathogenic species. This thinking is supported by data showing that the majority of cases were based on single IgG results just above the cutoff titer, which were drawn early after symptom onset before an antibody response could be measured. It's also consistent with the fact that today's serologic tests can't differentiate between infection by more serious versus less serious disease species, and fewer cases are being confirmed with species-specific testing like PCR on whole blood or rash biopsy specimens. We have a good understanding of the pathology of Rocky Mountain spotted fever, but less so for the emerging rickettsial species. Rickettsia rickettsii bacteria infect phagocytic cells on the skin around the bite site, where they remain for several days. The process of inflammation begins primarily affecting the lining of the blood vessels, but during this period, high levels of virus are present in skin cells. The inflammation manifests externally as the characteristic Rocky Mountain spotted fever skin rash. Inflammation of the walls of the blood vessels spreads, leading to systemic vasculitis. If untreated during the early days of symptom onset, injury to the walls of the blood vessels leads to vascular leakage of fluid and can quickly progress to pulmonary edema, acute respiratory distress syndrome, and cerebral edema. Tick-borne rickettsial diseases commonly have nonspecific clinical signs and symptoms early in the course of disease. Although the clinical presentations overlap, the frequency of certain associated signs and symptoms, such as rash and other cutaneous findings and lab findings, differ by pathogen, as do case fatality rates. Familiarity with the clinical findings expected in the different rickettsial diseases, as well as other tick-borne diseases, is necessary for healthcare providers to develop a good differential diagnosis, prescribe effective antibiotic therapy, and order the diagnostic tests that can confirm the species. Without treatment, Rocky Mountain spotted fever progresses rapidly, with case fatality rates as high as 20 to 25% if patients aren't treated until day 8 or 9 after symptom onset. One of the main differences in early clinical presentation between the less pathogenic and more pathogenic rickettsial infections is the type of cutaneous symptoms. With the less pathogenic infections, a dark scab or crust called an eschar is often present at the bite site, and rash may be faint if present at all. Rocky Mountain spotted fever presents with a rash that begins on day 2 on the wrists and ankles, then spreads centrally. If the rash areas coalesce, it can lead to blood circulation problems and peripheral gangrene as early as day 5. The antibiotic doxycycline is most effective if administered within the first 5 days of symptom onset. Many diagnostic challenges remain in sorting out the more serious versus less serious species of rickettsia. First, we don't know the percentage of the population who have existing antibodies from previous infection with the different rickettsial species. Second, although it's good that people usually seek care within the first few days of symptom onset, serum drawn at that time may not contain measurable antibodies. Next, for reasons that we're just investigating with New Jersey healthcare practitioners, species-specific tests like biopsies, cultures, and whole blood PCR are not often obtained. Once treated, people feel better, and a convalescent serum specimen that would reflect a true titer increase is rarely collected. And finally, healthcare practitioners are still ordering IgMs that researchers now believe result in many false positives due to cross-reactivity. So here's what CDC is currently recommending and what we'd like to promote here in New Jersey, preferably before antibiotics are begun, but without delaying treatment. For persons with suspected nonspecific tick-borne disease symptoms, providers should perform a tick-borne panel. If patients present at day 3 or more after symptom onset or are severely ill, collect a whole blood specimen for PCR, as well as a serum sample. In addition to acute serology, obtain a convalescent serum 2 to 4 weeks after symptom onset. And whenever possible, perform a biopsy of the rash or a swab of the eschar for PCR testing, along with a serum sample. In the past month, with the help of a preventive medicine resident on rotation in our department, we interviewed 15 healthcare providers who treated 3 or more spotted fever group rickettsia for the past 5 years. Providers were asked about their current testing strategies, capacity to perform biopsies and collect whole blood specimens in the office, and willingness to obtain additional specimens. We plan to work with healthcare providers to promote collection of more species-specific specimens and may need your assistance in conveying this information. Hopefully, we might be able to see a difference by monitoring lab results in CDRSS, but we may also need to ask providers about negative test results obtained. Again, recognizing the burden of tick-borne disease cases, We'd ask that you investigate cases in as timely manner as possible. To assist, we'll be providing a new spotted fever group rickettsiosis investigation worksheet, which will include the important symptoms and risk factors like presence and type of rash or an eschar at the bite site. New Jersey Department of Health will provide you with messaging to encourage healthcare providers to obtain a convalescent specimen at minimum and more species-specific testing if possible. For case classification, the holy grail for confirmatory results would be a positive PCR for a Rickettsia rickettsii or another spotted fever group. But if a convalescent titer was performed and shows a fourfold increase in IgG, that's also confirmatory. Supportive results include preferably an elevated IgG antibody versus IgM that's above the reference range of the reporting laboratory. Usually this titer is greater than or equal to 1 to 64. Required clinical criteria include fever plus presence of one or more of the conditions listed in the box to the right. A confirmed case must meet confirmatory lab criteria and have had a fever and at least one of the other symptoms. A probable case must meet supportive lab criteria and have had a fever and at least one of the other symptoms. If lab criteria are met but clinical information could not be obtained, classify the case as possible. And we have another poll question. So you see some laboratory results and 3 symptoms, and we'd like you to classify this case. Okay, well, we got a lot of different results on this one, but we got the fewest responses to the correct answer. So in this case, it would be classified as not a case. There's supportive laboratory evidence of infection, but there's not a reported fever, which is required in this case definition. So we'll move on to what we plan for spring and summer activities. So for this year, for spotted fever group rickettsiosis, New Jersey Department of Health will be posting our updated spotted fever group rickettsiosis chapter and the new investigation worksheet by the end of this month. We'll also be reviewing the capacity of CDRSS to receive all the species-specific results that are necessary to receive. We're going to follow up with the healthcare providers that we interviewed on the pilot surveys and develop guidance about collecting more species-specific specimens, which we'll provide to you through your regional epidemiologist. We're also planning to develop a links message to reach a broader healthcare provider audience beyond just the 15 physicians and healthcare practitioners that we interviewed. On your part, we'd ask that you focus on gathering complete information about signs, symptoms, and risk factors, particularly the description of the rash or the eschar. We'd also like you to remind healthcare providers to collect convalescent specimens, and when we develop that information about more species-specific specimens and how to collect those, we'd also like you to pass that information on to healthcare providers. So I'd like to acknowledge first and foremost Lindsay Lowe, who I think many of you know, and she's our machine in processing, evaluating incoming lab results, and reviewing case classifications. And so many thanks to her. And also Dr. Jennifer Bagley, the preventive medicine resident who interviewed New Jersey healthcare providers about spotted fever group rickettsiosis. Just clicking. We also have 2 quick other vector-borne disease updates. The first one is on dengue. In 2015, the dengue virus case definition was updated by CDC to include 3 disease subgroups based on clinical presentation. This slide is a quick reference for classifying dengue virus cases in CDRSS and will be placed in the dengue chapter on the DOH website. The big message is that all cases need to be investigated and meet the case classification for one of the disease subgroups. So in your case investigations, first, determine the symptoms. Next, based on the symptoms, assign a subgroup to the case, and then use the laboratory results to classify the case in CDRSS. The dengue investigation worksheet contains most of the information required to complete the case in CDRSS. As a reminder, local health departments should complete the investigation and close cases in CDRSS with creation. And finally, specific to our federal Zika grant, CDC requires us to report on 2 indicators that measure the timeliness of response, both of which have a goal of within 48 hours. Data is required on confirmed and probable cases as well as suspect cases. Anyone approved for testing at FEL is considered a suspect case. The first indicator is the timeliness of when a public health investigation is initiated. And for this indicator, no additional action is needed on your part. For the 4th quarter of 2017, 98% of Zika reports had an investigation started within 48 hours, mostly because 98% of the cases were created by the local health departments. The second indicator measures the timeliness of when control measures are implemented. For the 4th quarter, only 75% of cases had documentation that control measures were initiated within 48 hours. Even with decreased disease transmission worldwide, it remains important to implement control measures quickly, ideally at the time the request for testing is made, to protect the patient's unborn child and sexual partner, and to make sure the virus doesn't infect mosquitoes in New Jersey. These important actions will require some additional steps on your part. Examples are listed on the slide, and many of you are already doing these, such as including key prevention messages on the fax you send to providers with the SRD1 specimen approval form, verifying verbally that a provider has educated the patient, providing the education directly to the patient, or notifying the county mosquito control agency to assess the home environment. Whichever control measure was implemented, it needs to be documented in the comments box in CDRSS. All that is required is a brief description and the date it was provided. For example, on 1/15, provided education to provider on mosquito avoidance, sexual transmission, and time frames to wait for conception. For some physician practices, you may know the provider educated the patient when the test request was made, but if you don't include the information in CDRSS, at CDS, we don't know that and can't report it to CDC. If you don't have control measures documented in CDRSS, you'll receive emails from the Zika team to try and obtain this information. The link to the Zika chapter is at the bottom of the slide. On page 12 of the chapter, there's a description of what is needed in CDRSS. Thank you very much.
All right, thank you very much, Karen. Next we have Della. Introduce yourself.
Yes, thank you. Hi everyone, my name is Della Dargina. I'm the CDRSS coordinator. I'm going to be sharing quick updates on the new CDRSS redesign, now known as CDRSS 2.0. I'll talk specifically about the training plan and preferences for the new system. So after gathering feedback on training preferences, we have a couple of different training options for training current CDRSS users for the new system. The first option is a webinar by CDRSS admins that will be available, which will review new system features and functionalities, ending with a live question and answer. The webinar will be offered multiple times a week with the option for you to register for your preferred date. The second option is in-person training by CDRSS admins lasting about half a day. These will be held at the various regional medical coordination centers across the state. In addition, there will be a number of short or tutorial video resources on the main topics in CDRSS and all the new features that will be available on the website for you to refer to as a resource at all times. At least one of the webinar or in-person will be required to gain access to the new system. You can choose what works best for you or a combination of one or the other, and then the video resources will always be available. So you can pick the best option depending on your schedule. The tentative timeline for training is to have the webinars available all throughout March, specifically for lab and hospital staff. April will be for in-person trainings for hospitals and local health department staff and any other facility users that can attend the in-person training. Additional webinar trainings will be available all of May. So from the information we received from the last CD forum survey, we gathered from over 250 responses that about 100 the webinar and about 75 preferred in-person. So most hospitals and labs preferred webinars, while more local health staff preferred in-person. So we will schedule the trainings accordingly and have options for both. Thank you again to everyone for participating in that survey. So I wanted to share one other update. We have been waiting for the IT security approval, which would allow access to the CDRSS 2.0 testing site to users outside of our internal network, so all of you, and that recently passed approval. So please be on the lookout for additional updates regarding access and the training schedule, which will be posted on the main CDRSS page soon. Also, a survey has been posted on CDRSS to receive additional feedback on your preferred training method. Please complete the survey by February 20th, as your responses will be really helpful in finalizing the training details for us. After this survey is completed, the additional training details and schedule will be posted to CDRSS for your reference. Please note, if you completed this training survey at the last CD forum, you do not have to complete the survey again. If you encounter any issues with the link or accessing the survey, please contact our help desk email. Again, thank you for all your efforts with CDRSS reporting, and feel free to reach out to our help desk at the email listed if you have any questions at all regarding the new system or training. Thank you.
Thank you so much, Della, and thank you to all of our speakers. So just a couple reminders before we close out the webinar and get to your questions and your answers. You must be registered on both GoToWebinar and NJLMN. We will send you out a link via email to the evaluation. Please make sure you fill out the evaluation. It's going to be emailed only to your NJLMN address. So if you're not on NJLMN, you're not going to receive the link. So make sure you get registered on both GoToWebinar and NJLMN. You must complete the evaluation for continuing education credits. Certificates for nurses will be emailed after evaluation closes, and once the webinar is posted to our website, we are going to notify you again via NJLMN. So you will receive a link to the evaluation after the webinar. The evaluation link, again, sent to your NJLMN address, and you must complete the evaluation to get credits. You're going to have 5 business days, so not including weekends, but 5 business days after we send it out for you to do this evaluation. After the evaluation closes, certificates will be emailed to you and attendance will be verified. Those who do not complete the evaluation will not receive credits. So again, we thank you so much for participating. We hope you found this information valuable and helpful. Your continued support of the Communicable Disease Forums is greatly appreciated, and information about the next CD Forum will be announced shortly. So with that, we're going to do some questions and answers. Again, right now, if you have any questions for any of the speakers, go ahead and type those into the question feature. And we're going to go through some of the ones that we went through today. So we'll just go in the order of the way we had our presenters go. And again, right now, if you have any questions, go ahead and type them in, and we'll go through the questions that you already asked.
So this is Jessica. It looks like ICAR received a question regarding catheter and other vascular accesses and what the ointment at dressing changes was. So the CDC ICAR tool is broken down into domains, one of which is catheter and other vascular access care. One of the questions within that domain inquires, does the facility routinely apply an antibiotic ointment or povidone iodine ointment to catheter exit sites during dressing changes? So most facilities, majority of facilities answered no to that question, which made that domain an opportunity for improvement based on the tool. Forms of vascular accesses in the hemodialysis community would be a fistula or a graft. When we talk about a catheter, we're talking about a central venous cath. CDC published for guidelines for prevention of intravascular catheters at the B. So if a facility did not apply for purposes of data evaluation, that was a no and an opportunity for improvement.
Thank you, Jessica. Do we have any from Rini? No questions from Rini? Okay, we had a question for Deepam.
Hi, this is Deepam, and the question for the foodborne team was how many salmonella cases were estimated versus those that were actually reported? 30,000 to 40,000 culture confirmed cases of non-typhoidal salmonella that are reported every year to CDC. In New Jersey, there are approximately 1,000 cases. Every year we had 1,051 in 2016. So these cases are really only estimated to represent 1 to 5% of the actual case count. So while our investigation remains the same, a reported case for us is a positive either by culture or by CIDT, which is a culture independent diagnostic testing. But remember, for a case to be reported, a person must be sick enough to seek medical care. The physical